This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery.
And I'm Dr. Ilara, a research fellow. Today, we're looking at a fascinating new study from the journal Neurologia medico-chirurgica, published in 2026. It's titled Experimental Development and Internal Validation of a Clinical Prediction Model for the Occurrence of Idiopathic C5 Palsy After Laminoplasty, led by Dr. Echezenia and colleagues from Hokkaido University.
This is a topic that hits home for anyone who spends time in the spine OR. We've all been there. The surgery goes perfectly, the decompression is beautiful, the patient wakes up, and then, a day or two later, they can't abduct their arm. The dreaded C5 palsy.
Exactly. And what's frustrating is that it often occurs idiopathically, meaning it wasn't a direct surgical trauma to the nerve. It's a major complication of posterior cervical surgery, specifically laminoplasty, and despite decades of research, predicting who is going to get it is still a bit of a black box.
This study tries to shine some light into that box. They looked at 180 patients who underwent double-door laminoplasty at a single institution. Ilara, before we get into the model they built, what was the actual incidence of C5 palsy in their cohort?
It was exactly 10%, 18 out of the 180 patients. That's very much in line with the literature, which usually quotes anywhere from 5 to 15%. They defined it as a decrease of at least 1 grade in the manual muscle test, MMT, of the deltoid or biceps within 2 weeks post-op.
So the meat of this paper is how they tried to predict those 18 cases using preoperative data. They looked at several radiographic parameters. Some are classic, like the width of the intervertebral foramen, or WIF, but they also looked at the C7 slope.
Right. The C7 slope is an interesting choice. Most of us are used to looking at the T1 slope for sagittal palans, but as the authors point out, T1 can be hard to see on lateral x-rays because of the shoulders. The C7 slope correlates well with T1, but is much easier to measure.
Let's talk about the predictors that actually made it into their final model. They used logistic regression and then adjusted for optimism using bootstrapping. What were the big 4 variables?
The final model focused on age, sex, the width of the intervertebral foramen at C4/5, and the C7 slope.
Let's break those down. The width of the intervertebral foramen, or WIF, is something we've suspected for a long time. The traction theory, right?
Exactly. The theory is that when you decompress the cord from behind, the spinal cord shifts posteriorly. If the C5 nerve root is already crowded in a narrow foramen, that posterior shift puts even more tension on the root, leading to palsy. In this study, a narrower width was a significant predictor. The coefficient was negative 0.721, meaning as the width decreases, the risk goes up.
And then there's the C7 slope. This is where it gets interesting for the residents listening. Why would the tilt of the C7 vertebra affect a C5 nerve root?
Well, the authors found a positive coefficient of 0.054 for the C7 slope. This means a higher C7 slope, meaning a more tilted base of the neck, increased the risk. It likely relates to the overall sagittal alignment. A higher slope often means more cervical lordosis or a greater compensatory shift, which might influence how far the cord drifts back once the laminae are opened.
It's all about the mechanics of that spring back of the cord. Now, what about the demographics? I noticed the sex coefficient was negative 1.161 for female.
Yes, which implies that being male is a higher risk factor in this model. We've seen this in other studies too, though the reason isn't entirely clear. Perhaps it's related to larger muscle mass or different foramen to nerve root ratios in men. Interestingly, the age coefficient was negative 0.039.
That's a bit counterintuitive for some, as we often think of older, more degenerate spines being at higher risk. But in this specific model, that negative coefficient suggests that when holding everything else constant, younger patients in this cohort had a slightly higher risk profile.
It's important to remember that these models look at variables in combination. The researchers didn't just stop at identifying these factors, they built a model and validated it. For the residents listening, the area under the curve, or AUC, is the key metric here. Dr. Aris, how did the model perform?
Initially, the AUC was quite high, at 0.797, but, as we know, models often perform better on the data they were built on than they do in the real world. After they performed internal validation using bootstrapping to adjust for optimism, the AUC settled at 0.736.
A 0.736 AUC is actually quite respectable for a clinical prediction tool. It's not a perfect crystal ball, but it's much better than a coin flip. They also reported a Breyer score of 11.7%, which measures the accuracy of probabilistic predictions. Lower is better there, so 11.7% is pretty good.
So if I'm a resident in the clinic seeing a patient with cervical spondylotic myelopathy, and I'm planning a C3, C7 double-door laminoplasty, how do I use this?
You'd look at their CT and measure the C4-5 foramen width. If it's narrow, say less than 2 or 3 millimeters, your ear should perk up. Then look at the standing lateral X-ray. If they have a steep C7 slope, you're looking at a high-risk candidate.
And that's the moment for the informed consent conversation to get very specific. Instead of saying, there's a 5 to 10% chance of arm weakness, you can say, based on your specific anatomy, your narrow foramen and the slope of your spine, your risk is higher than average.
It also might change your surgical strategy. If the risk is high enough, some surgeons might consider a prophylactic foraminotomy at C4-5, although that's still a debated topic in the field.
It also reinforces the importance of the surgical technique they used. They mentioned the gutter was created slightly medial to the lateral mass, and the opening angle was 60 to 90 degrees. If you're pushing that opening further, you might be increasing that posterior cord drift.
One thing I found interesting was what wasn't a major predictor in their final model. The C2 to C7 Cobb angle and the presence of OPLL, ossification of the posterior longitudinal ligament, didn't make the final cut, even though OPLL is often thought to be a risk factor because of the severity of compression.
It goes to show that the dynamic or spatial relationship, the distance the cord travels, might be more important than the cause of the compression itself. Now, every study has limitations. This was a single center study, right?
Right. 180 patients is a decent size, but it's still one institution and one surgical style. The authors used internal validation, which is a great first step, but we really need external validation, meaning testing this model on patients from a different hospital before we can say it's universally applicable.
Also, the definition of C5 palsy can be a bit subjective. They used a drop of 1 grade in MMT. Some studies use a 2-grade drop, which would obviously lower the reported incidence. But I think for a prediction model, you want to catch even the milder cases.
Definitely. They also didn't account for intraoperative neuromonitoring changes. It would be interesting to see if the model correlates with MEP or SSEP drops during the gutter creation or the door opening.
That's a study for the next fellow. So to wrap up, we have a new validated model for C5 palsy. The key takeaways are to measure the C4-5 foramen width on CT and the C7 slope on X-ray. Males and younger patients in this specific study showed higher risk.
And the model's formula is there in the paper for those who want to get technical. It's 0.054 times C7 slope, minus 0.039 times H, minus 1.161 for females, minus 0.721 for WIF.
It's a great example of how we're moving towards personalized neurosurgery, using a patient's own radiographic print profile to predict their recovery.
Well, that's our time for today. We hope this helps you in your next spine clinic or in your prep for the boards.
Thanks for listening to the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.
Keep aiming for those perfect decompressions. Safe scrubbing, everyone.